Hello, I'm Jeffrey Taxman, and I know working in the emergency department can be stressful much of the time. But with COVID-19, there are particularly strong and difficult stresses and pressures that may be affecting all of you. I hope this presentation will be helpful in that regard. Today, we're going to be talking about the impact of massive community trauma on communities and particularly EM staff from a psychological and psychodynamic perspective. The material is from experiences that I had working with first responders, including police, firefighters, soldiers, and medical personnel in New York, Amman, Jordan, Sri Lanka, Nepal, and Haiti. This is a picture of the surgical group that I was embedded with in Haiti. The surgical suite is actually a hastily converted storage room. And you're looking at, in the lower left, the one ventilator they had for the whole clinic. The goals for today will be to get an understanding of the psychological impact of disasters on a community, with looking at special stresses of emergency medicine physicians and staff during a disaster, and then what strategies we can use for self-care and for helping others, your colleagues and staff. So looking at social structures, communities are dynamic social structures, and like all dynamic complex structures, they're endothermic and take work and energy to maintain their integrity and function. And we as a society aggregate into ever expanding, more complex groups in order to allow and maximize individual, professional, and social functioning. Some of these structures are concrete, like families, schools, countries, states, the emergency department. Those are all concrete structures that, again, take energy to maintain the functioning efficiently. And some are conceptual structures. Trauma applied to these structures can lead to the breakdown and regression of those in it. By regression, I'm talking about, just like individuals, as we develop, we have higher and higher levels of functioning and higher levels of structure and defense in order to overcome stress and anxiety and fear. In traumatic situations, individuals and communities tend to regress to lower level functioning. I'm sure you're all familiar with working with borderline patients that come into the ED. Well, many people talk about community structures and organizations as regressing to a borderline structure during high levels of stress. That is, they regress, they become rigid, and it becomes adversarial. So looking at stress, trauma, and disaster, as you know, stress is just a pressure or tension applied to a structure that disturbs its equilibrium. Most organic and social structures have mechanisms in place to return to equilibrium and functioning. A trauma is a stress that exceeds the organism or organization's capacity to return to its normal functioning and equilibrium. A disaster I define as a trauma that occurs at the level of a community and destroys the infrastructure and the ability of that community to function. It overwhelms the resources and infrastructure, the political, social fabric of the community, and threatens the safety and function of the community. One of the reasons that last statement is important is, as I said a few minutes ago, the ED and the hospital are structures like I just defined. And under enormous pressure, they can regress, and the ability of it to maintain its equilibrium and functioning can be threatened. There's many different types of disasters. You're all aware of them: natural, human-made, willful. The reason this is important is we as individuals as well as communities respond to different types of disasters differently. Again, we use defenses, distancing, displacement, denial. If there's a major earthquake, you can be sympathetic, you may even go to help, but you can say, I don't live in Nepal, I don't live in California, it's not going to affect me. It's a way to keep you and those around you and your social structures safe mentally, and you can go about doing your business. Some, like for a while, Fukushima and Chernobyl, we were worried that there might be something that might spread everywhere. But once that was mitigated, most of us went back to our normal lives, and we really didn't have a pandemic-like disaster sense affecting our communities. Now, with the pandemic, it's affecting everybody. And there's not much of a way to use the normal defenses to say, I'm not going to be affected. Many disasters activate old, primitive fears and conflicts. Some of these are collective, as in the whole community or country or religious groups. And these collective things that get resonated with are often passed down generationally or through churches or schools by cultural lore, fairy tales, children's books, things that parents tell their kids. And some disasters, and we're seeing this now, activate individual conflicts that had been resolved and passed through many years ago. Fears of abandonment, for example, a young child, a 2-year-old, 3-year-old, who's afraid that their parent may not come back when they don't know where they are, or a child gets lost. Issues that we deal with at 2, 3, and 4 of independence and autonomy, or how we dealt with shame, guilt, honor. These are all things that we've incorporated as we grew up. And certainly for most of us here today, issues of independence and autonomy are paramount. I think most of us prize our ability to be autonomous, make independent decisions, be strong, and take care of others. So the concept of honor and doing the right thing is very strong. Now, the impact of a disaster on a community depends on many factors. I mentioned the one, that is distance from the actual disaster and whether you have proximal contact with it. But the scope and size of a trauma also makes a big difference. If it overwhelms the community's adaptive mechanisms, like an earthquake that wipes out all the hospitals in Port-au-Prince, that certainly magnified the effects of the earthquake on people because they couldn't get treatment for relatively simple traumas. It can also deplete the critical mass needed for a community's functioning. It can wipe out a rural community's workers. It can damage plants where the critical mass for resources are produced. And the biggest concern, and one of the largest sources of panic for the general public, has been, will the illness and the need for treatment overwhelm the hospitals? Now, that's the way the community at large has been panicking, but obviously you're the recipients of that, and you're the ones who that's all been aimed at. So if we're talking about the community's adaptive mechanisms or the critical mass needed for treatment being depleted, you're hearing every day about how you may end up being depleted. And that reverberates with your own potential fears about infection.
So Dr. Taxman, as you were talking about that, something like just kind of resonated with me that I feel like also like we've already been overwhelmed, right? Like we don't all have the N95 masks that we want. And I think that has like raised up a lot of these fears in us now. And I also feel like I've seen more sort of that like us versus them tribalism that's been building up. And it just seems like that really fits into this kind of course that you're talking about.
Yeah, that's exactly why I'm talking about those things, is that is what happens. And maybe especially very high functioning people like EM staff and other physicians. You may not realize that under this kind of stress, we and the organizations we work with and even our patients end up in that us versus them.
Mm-hmm.
And that's not the way we're supposed to be thinking about it, and that's not what we're comfortable thinking about. So the previous slide talking about the impact leading to overwhelming the adaptive mechanisms and the critical mass and resources, that happens at a community level, but as Wendy's pointing out, it also affects the individual. We're all afraid we won't have enough of the protective equipment. We're all afraid that we won't have enough ventilators. And whether that happens or not, the fear is already in the head. Now, for many of these, you are actually dealing with that depletion of resources. I'm going to touch on the time course of a disaster because that has a large impact also on how a disaster affects the community at large and also how it's affecting all of you. We somewhat arbitrarily define impact phase as the first 24 to 48 hours. The acute stage is up to 2 months, 1 to 2 months after the initial impact. And then post-acute is beyond the 1 to 2 months. That can last 6 months to 2 years, and sometimes indefinitely for some communities. This is a graph of what I just described. And I think this is an important graph with important information for you, both in general, but also specifically about what you may be facing. This is talking about the stages of community response to disaster. And on the y-axis, we have community functioning, an arbitrary scale of how well a community functions. And on the x-axis, the time going forward, we have this arbitrary level of pre-disaster functioning of a community. It's going along at its regular pace. At impact, there's the decrease in functioning due to the chaos, the destruction, perhaps infrastructure destruction, distraction by people. The community functions worse right after impact. But then we see an interesting thing occur with individuals and a community at large, and that is there's a dramatic increase in community functioning, in cohesiveness, in the ability to be a functioning, helpful community. And we call that the heroic phase, and it's because everybody is trying to do what they can to defeat the enemy, if you will, to take care of the problems. People care for each other. When I was at ground zero a couple days after the buildings came down, everybody was willing to help everybody else. Restaurants didn't charge first responders for food or for water. If you needed a place for shelter, people would take you to one. Everybody was trying to help the other. But then what happens after a certain amount of time, usually days to weeks, that heroic period stops, and we actually end up going into a significantly worse level of functioning. Interestingly, considerably worse than when the impact occurred in the first place. And that's usually because the resources, which are limited, begin to dry up. Both the internal resources, the individual's willingness to give everything they've got, when their own demands begin to catch up with them. In addition, people begin to think not of the disaster and what they need to do about that, but their own lives. That is, I can't give you my water because my family needs it. I can't come in for an extra shift because I'm just too exhausted and I'm afraid I might get injured or sick. So people start to pull back, take care of their own, and the ability to function as a community deteriorates. This happens on an external basis as far as external functioning, but it also happens internally as people get more and more regressed, withdrawn, angry, scared, and frustrated. And one of the concerns that I have as a psychiatrist looking at communities is if this continues long enough, both the illness, which increases fear and anxiety, but also the isolation, the unemployment, the inability to get resources. I'm concerned that we're going to see increasing social unrest and civil unrest. We may have many secondary injuries and fallout and morbidity from the social unrest. Now, after a certain period of time, and that period of time is usually when the community at large has had a chance to take a breath, survey the damage, and begin to reconstruct what to do, how to take care of the damage as well as rebuild. And over a period of months to years, the community rebuilds, and actually, after it's done, usually ends up rather higher level than before. Why is that? Number of reasons. One, after a disaster, much old dead wood and obsolete infrastructure has been cleared out, like in the Chicago fire, and has been replaced with more modern and better functioning infrastructure. In addition, internal resources. People learn to work with other people. We learn new techniques. Right now, we're probably learning how to speed up the production of vaccines. There's communication. Everybody is learning how to communicate over the internet of all ages. So there are things that people do in response to a disaster that lead to better functioning communities, including hospitals, emergency room groups. Now you'll notice during that reconstruction time, there are periods of setbacks where functioning drops again. And those are either trigger events or anniversary reactions. In the terminology and in the context of COVID-19 and the emergency rooms, what would those be? Well, the graph that I'm showing you is for a static instant disaster, like an earthquake or an explosion. This is more of a rolling disaster, where hotspots will rise and decrease. There's so much media. What may affect you as far as a trigger event or an anniversary reaction is people start hearing about a hotspot in another area. They develop some URI and they're going to start coming into the emergency room. Or next year, as our seasonal flu comes through and people do start developing significant respiratory and pulmonary problems, that may trigger both in the EM staff and in patients a fear not based on normal everyday dealing with pulmonary issues, but a resonating with what happened in 2020. Some of the reactions you may see in a dramatic disaster, you'll often see stunned, shocked reactions, a sense of being abandoned. We're seeing a fair amount of that right now because of the isolation, but also because of the sense that nobody, including our caretakers, the government, hospital administration, even physicians, know what we can do with sureness. And so it often feels to those who are supposed to be taken care of by these establishments that we're being abandoned. Now that goes back to my developmental model. We're not being abandoned. Everybody's trying the best they can, but it may feel more like abandonment than one might have felt when one was younger. We have uncommon vulnerability. We're susceptible and sometimes pass on exaggerated rumors. I'm sure you hear that in the ED. You hear this is going to happen next week. They're instituting this tomorrow. Doesn't happen. You may also experience intense senses of altruism, wanting and feeling good about doing everything you can, feeling affection and love and kindredship with some of your colleagues, or the opposite, and a sense of heroism and productivity. That's very good. That's why people like first responders run toward the problem, but that can wear thin after being on site or in a hot zone for a very long time. PTSD, post-traumatic stress disorder, is not just severe stress. It's involved with a very specific time course versus acute stress, which is during the episode. And it is a physiologic as well as psychologic diagnosis. There are physiologic problems that come along with it. The rescue workers, first responders, people in your situation do have a roughly 10 to 20% risk of developing PTSD. The general population who are not immediately affected also have a 1 to 10% increase, and direct victims between 30 and 40%. With all these problems, we need to remember that most people in most communities and most social structures are quite resilient, that we're able to tolerate an awful lot of stress and an awful lot of trauma without breaking. Start with who you are. I mean, you're a special breed. You're self-selected as certain types of people. This is a gross generalization, but most of you, as we say, are type A. Most of you like the pressure you're normally under, you respond well to it, and you rise to the occasion. You like the responsibility and you expect it. You have a professional persona. You know that you're that special breed. You see yourself as essentially the elite. You're trained and expect to be able to treat anyone, anytime, for anything. And I think you suitably wear that badge with honor. Your training and praxis, the way you work is pretty much the same every day. You maintain your high level of diagnosis and treatment and the expectation that you can treat anything and stabilize people. You have and expect autonomy and take responsibility for your clinical decision making, and you expect to be treated that way. You've also developed what I call an emotional and intellectual bifurcation. It's that you have plenty of both emotional responses and intellectual responses. What you've learned to do, of course, is to separate them when needed. You can be very compassionate with your patients, with patients' families, but you know how to take the other path when you have to do what you need to do, and you can shut the other off. And you do that pretty well at will. Now, in a disaster, and particularly with COVID, many of these are threatened. The training, the professional persona. This is a disease where it may not show up when they walk into the ED, and you may be thinking, am I going to get it right this time or not? The responsibility and autonomy. You're being told many things from many places, the CDC, the government, the hospital, and it's changing all the time. This emotional versus intellectual bifurcation is getting threatened because the emotional side is building up. The anxiety, the constant being on edge, the being alert all the time is filling that side more than you're used to being able to control. Do you need help with this? Most type A uniforms, cops, firefighters, soldiers, and surgeons and ED staff usually say, no, I can handle this, because you usually can. You're used to dealing with very stressful situations, and that gets you sharpened and focused. We're back to my friends here from Haiti. This was a surgical group that I was implanted with, and when I first got there, most of them were sort of scoffing, we don't need no stinking shrinks, we know what we're doing. And they very happily proceeded to do what they could in MASH unit type settings. And because it was an earthquake with pretty shoddy buildings that had collapsed, a lot of these were crush injuries. And they were performing many amputations, which were necessary at the time to save the lives of the patients. But they were working maybe 20 hours a day. About 2 or 3 days in, they began to fall apart. Some of them wanted to leave. Many of them were depressed, tearful. And what it turned out most of this was about is they were working with subpar equipment. They didn't have what they needed to do the kind of work they would have done in almost any hospital in the US. They didn't have dermatomes. They didn't have the ability to do skin grafts. They had one ventilator. And they began to think that they were harming patients more than helping them, that they weren't able to do their jobs, that they weren't performing as good surgeons. In fact, some of them even said, I'm performing worse than a surgeon that I had testified against for work that he had done that was better than what I did yesterday. So it takes a tremendous toll on the professional persona and one's praxis at work. Some special stresses for ED staff. Internal stresses, just within yourself, conscious and unconscious. There's, first and foremost, your own fears of getting sick or dying. Those are very real and they're very present. And it's not just when you're in the ED. When you go to the ED, it heightens your fear that you may catch something. But I doubt for many of you that fear goes away once you've left. You don't know if you caught it yesterday, which brings up the fear of being a vector for your family. Are you going to bring something home? Are you going to infect the ones you love? Are you afraid to touch them? Are you afraid to be close? You may have worries for loved ones and colleagues. A very difficult stress is the heightened and sustained high level of alertness. This is very similar to what happens to combat soldiers when they're gearing up for a patrol, when they've been given information that they suspect an attack on their base, or when they know they're going to engage in a firefight, but they don't know when. They're at an extremely high level of alertness, which taxes them physically and mentally, and that can go on for days. And that's what you're doing now. And you can't sustain that for too long. It drains one psychologically and drains one physically. It's also very distracting. Burnout. We'll talk more about that in a minute. There may be a number of feelings regarding your coworkers. There may be anger at some who are not acting in a certain way. Maybe they're being cavalier. Maybe that's their defense. Maybe they're too afraid and they're talking about it and you don't like hearing it. Maybe they're taking off and you're thinking that's not fair. Or maybe you've taken off and you feel guilty or ashamed, or you may feel guilt or shame about your own fears. You look around you and say, well, nobody else seems to be worried. Well, most are. Another one that's particularly stressful is anticipatory crisis and disaster is already in your head. That is, for weeks now, we've been told over and over, rightly or wrongly, that there's going to be this mass flood of patients. We're going to overwhelm the hospitals. We're going to need more ventilators than we have. And the corollary to that, and some hospitals have even been distributing worksheets about this, you're going to have to make decisions about who lives and who dies, who's given a ventilator and whose family is told, no, I'm sorry, grandpa is too old, he can't have it. Now, the scenario I just said may not even be ethical or legal, but that's what's been getting discussed. That anticipatory end stage crisis has been in most of your minds for weeks now. And the anticipatory crisis leads to that sustained high level of fear and alertness and burnout. There's also an anxiety about potential decreased quality of service. If you're being told certain things are okay to do that you know aren't, that may make you feel anxious. Or your own fears, staying outside of the room longer, being distant from the patient, having a more cursory exam. There may be fears that you may miss something. Now, most of us have those fears anyway when we approach complex patients, but this would make it worse because there's a reality piece that you may not be spending as long a time with them. Additionally, how you feel about your job may be affected. You used to feel safe other than very rare situations walking into the ED. In fact, it was sort of your kingdom. And now there's constant sense of risk and reminders of those risks, the donning and doffing, the carefulness, the observing other people, making sure that you're not going to be exposed. Most of you, I assume, are very confident when you approach a patient. Even when you don't know what's going on, you know you can figure it out. Now, most of us may be hesitant or even fearful approaching a patient, not about the diagnosis necessarily, but just, is this patient going to hurt me? Am I going to catch something from them? And that changes the praxis. These that I'm listing now change the way you've done things for years. And for many, it used to be hard work, but a pleasure being an ED physician and enjoyed being there. And now people are starting to think, I can't wait to get off my shift. I can't wait to leave. I can't wait to get out of this setting. Some maybe even think about quitting or taking another medical job. Not that they're going to do it, but that may be floating around in their heads. And that erodes one's professional persona. Any questions about the internal stresses?
Well, I can say for myself that I have very much felt that sort of impending sense of doom feeling. I think another stressor we have is that since all of our hours are being cut too, that there's like this financial stress on a lot of us as well, because we're not getting the hours and things that we're used to.
Yeah, I will address Wendy's comment about the impending doom. I'll go back later to that graph showing the time course. One of the things you may want to watch out for, both personally and as an ED group, is we're mounting this constant waiting for the tidal wave of massively ill patients and being overwhelmed. As paradoxical as it sounds, if that doesn't occur, that is, if flattening the curve does what it's supposed to, which is to help you and the hospitals, there may be an interesting reaction after it's all over. There may be a lot of anger among yourselves as well as the public. Like, you made us do all this, you ruined the economy, you had us go through all this stress, and it didn't happen. Now, right now, that sounds irrational because we're not through it, and it could still occur. I'm talking about a psychological response later down the road once one is safe. And we see this after every disaster. There's a lot of reworking what could have been done and what should have been done, or what didn't have to be done.
Yeah, I think one of the best things I've heard is that if we do this right, it will feel like we overreacted. And so
Correct.
we should aim for that. Yeah.
Right. And that is exactly true. It's a great statement, but it's also the first half. The other half is, what do people do when they've been injured by somebody else overreacting? They get angry. Try to remember this conversation a month or 2 or 4 down the road if people are starting to feel angry about the previous 4 or 5 months. In addition to the internal stresses, we have external pressures and stresses affecting all of you. Pressure from your family, explicit or implicit, usually pretty explicit. And that is, do you have to go to work? Why do you have to go to work? Can't you call in sick? The implicit fear of the family. While they're proud of you, are they afraid that you're going to hurt them? I think most of us probably feel some of this. I know I have. My wife, certainly my mother, my ED daughter, who I think would prefer me to be in a spacesuit if I go outside of the house. And I'm just going to a virtually empty office doing telemedicine with a few admin staff who have all been isolated other than coming to an empty office. You are going to the hot zone. So the family's fear is elevated, and I'm sure you're getting pressure from it. How do you deal with that? From the community, you're getting both positive and negative pressure. You're getting the positive pressure, which may sound odd. All the talk of being heroes, 24/7 on TV, you'll find an emergency room doc or an ICU doc or nurse, and they're being praised and they're told what heroes they are and how great they are. That's pretty hard to live up to after a while. And especially if you're developing your own concerns and fears and you may not be feeling heroic, that may increase the delta between how you view yourself and how you think you're supposed to be viewing yourself per the media. The negative, a lot of patients are scared. They're regressed when they're scared, especially if they feel it's life and death, and they may not be satisfied with your answer. They may have been given a runaround in order to try to get tested or to be treated, told to stay home. They're already angry. They come in and deal with you, and you may get negative reactions from them, either about testing, not testing, or the type of treatment you give them. There's certainly pressure from the hospital systems. You are the front line, and that's where the pressure hits. You have tension and pressure your full shift. Now, you're used to being very busy full shifts, and you're used to pressure if it's a busy shift. But this is different. This is the regular pressure plus the full shift fear and concern and anxiety about what's going to roll in next. Are we getting that avalanche today, tomorrow? And it's not just you and the patient's illness. It's the virus. Am I going to get that virus? Something I call the ER perspective added to the reverberating circuit. The ER perspective is a very special vantage point that you have about illness and injury. You see it up close and personal. For you, people not wearing seatbelts is very up close and personal. Motorcycle riders, you have your own perspective on that because you see the disasters. You see the first stages of ARDS before they get to the ICU. You see the pneumonias. You see what happens when people have severe illness. So you have your own perspective of what COVID-19 really looks like. Once you leave the ER, all you hear about all day is how bad it is. You don't get a chance for that day's residue to wear off. So I think you may end up with a very heightened sense of the lethality and fearfulness of this disease, and then that feeds back into your own concerns about being exposed to it. There's the faulty information you're getting. At your level of professionalism, you expect good information, and you usually expect to go to good sources that are reliable, get vetted, peer-reviewed information, and be able to incorporate it or not into your practice. Now you're being told changing information from unknown sources, whether it's CDC or something somebody said from a government agency, about things that you know weren't okay yesterday, like re-wearing masks, like practices that you know you wouldn't do under other circumstances than these. It's also infantilizing. And as I said before, you prize your autonomy and your decision-making and your sense of responsibility. You don't want to be treated like a child, especially with somebody telling you things that you know aren't true and they expect you to take it. One of my favorite expressions, crude as it may be, is don't piss on me and tell me it's raining. If you've got bad news for me, tell me, but tell me what it is. Don't lie to me and expect me to act like it's okay, I'll go do it. That's particularly destructive for people in your situation where you have to take that information and people's well-being and lives may depend on it. And again, it erodes that professional persona. Related to that are the changing or poor, quote, best practices. You know what best practices are. You keep current with them all the time. You try to provide them. And to be told that you're supposed to do things that are actually worst practices is confusing at best, insulting, and potentially harmful to both you and the patients. And very destructive is the actual or perceived or feared lack of resources to do your job. And I think all three are occurring. You have an actual shortage of resources that you need to be safe and to do your job well.
So Dr. Taxman, one of our attendees just shared as well that they find their partner's fear about getting, them getting ill leads them to minimize their conversation about work at home and then turning to other friends and classmates instead to offload and talk about work.
Yep. I think what I'll do is go forward a little bit to some of the things that we can do about those things. Because what they just suggested or discussed increases their own isolation and their own sense of keeping it to themselves. And it decreases one of the main things one can do, which is to be able to talk to people that you know and trust and to share some of your feelings and thoughts and concerns. Mm-hmm. And the last external pressure, by the way, is everything else. You still have everything else going on in your life, in addition to all these new stresses piled on top. Things to watch out for is in a disaster like this is over-involvement or an inability to separate either physically or your thoughts from work. The opposite, detachment, feeling cold or uncaring. Increased smoking, drinking, drugs. So let's talk about burnout. We often use that term to mean we've had a rough day, we're tired, we're frustrated. But in these extremely stressful times with ongoing high-level alertness and fear and concern, the risk of becoming burned out is very real. What you and your colleagues should watch for are the following signs and symptoms of becoming burned out. Your normal level of engagement and involvement with your colleagues and your patients may become replaced by feeling exhausted, cynical, and indifferent. Your usual level of compassion and patience for patients and their families may become replaced by frustration, bitterness, and anger. And the feeling of being part of a greater whole, part of the good fight, may be replaced by feeling alienated and isolated. These erode your professional persona and interfere with your praxis in the ED. Watch for these signs and symptoms, and if they occur, talk to a colleague, talk to a family member, or reach out to one of us, one of the people who have worked with professionals during disasters. There will also be a list of references of places one can contact at the end of this presentation. Very common to disaster physicians is feeling out of control, and that's something that you need to do your work. A sense of failure, not being good enough, not having done enough. This is just a quick slide. When thinking about your own stresses or how your colleagues are doing, this is a slide I took in a village in Sri Lanka after the tsunami. You can see the water level up here. I use it to point out, don't assume that the disaster is the problem. I asked people with this slide, what do you think the problem for this community was? There's the ocean back there. There's the damage to the community from the flood. People say, oh, it was the flood. No, it was actually all these 50 caliber machine gun bullet holes in the walls. This village had been caught between the Tamil Tiger and the Sri Lankan government civil war for years. And the flood was actually a relief. Being in a civil war that was the big problem. The flood gave them a reason to be out of the village and in secure surroundings. So with your colleagues and yourselves, don't assume that it's the pandemic that is causing some of the problems. There may be something underlying it that this is just bringing it out. How to take care of yourselves. The biggest takeaway from this slide, when you're in the field, when you're doing the work, you want to work in pairs or have a buddy or have a team approach so that you're not working isolatedly, that you can talk to each other about what you're feeling, what's going on, what the fears are, because it's much easier, especially in a regressed or stressed state, to give and take and figure out in a discussion what the real problem is and a real solution rather than just staying in your own spot. If you can, try to keep to a regular schedule. I realize you guys know yours in advance, but be careful if you start overworking or adding to the schedule. Get your rest. One thing to think of if you need to is Hilton hotel chains are offering free rooms for frontline medical workers. And you can get some of that information from ASAP or the emergency nurses group. Take breaks. I know your normal routine is it's hard to take a break and you've got your equipment on. You should try to take a break during these high stress times. That's the only thing that might even help weaken that chain of heightened anticipation. And that might be something that you can work out with your administration, how you can do that, how you can cover for each other, how you can take even a 5 or 10 minute break. Limit public news and media. Periodic self-assessments. You want to take some time to just think about how you're doing and watch for some of the signs of depression or stress in yourself and your colleagues. Be aware of the secondary stress. Secondary stress is the stress from a disaster or trauma, not from experiencing it yourself, but from witnessing and dealing with other people's reactions. And know what it is that you need in order to recharge or refill and make that happen. There's a few resources, articles that you can look at if you're interested. These are mostly for first responders. Psychiatry.org has a very good page for hospital workers, physicians, and I believe there's an ICU and an ED section. And this is an excellent resource for anybody who would like to speak to somebody about some of the stresses we covered. It's put out by the Academy of Experts in Traumatic Stress in conjunction with Green Cross CISM. At this website, aaets.org/frontlines-groups, you'll find over 80 screened therapists, all screened for their expertise and previous experience in working with first responders during disasters or crises. And what you'll find on the screen is a list of the therapists, their dates and times that they're available, their time zones, and in particular, their specialty and experience, whether it's with physicians, EMTs, medical personnel, or police. This would be a very useful and can be anonymous source to get some brief counseling. Your own EAP, as well as your own contacts. If you need to speak to somebody, use your doc network. You know people who know people. Find somebody that's done this before and that can be helpful. In conclusion, one of the biggest things that's important in a disaster is focus and who you are and why you're doing what you're doing, and to clear out some of the other issues that are rattling around in your head. And it made me think of a Ralph Waldo Emerson quote: "To know even one life has breathed easier because you have lived, that is to have succeeded." That fits with every one of you. This is why you do it. And you want to keep your mind focused on that, to remember who you are and why you do this, and to take care of yourselves.
Yeah, thank you. I just want to say, having been through this a couple of times now, I think it's hard to hear that very long list of the stressors that are on us. But I also find it like a little reassuring, like, no wonder I'm feeling this extra stress. Just acknowledging and naming those things, I think, is helpful. Um, so that we can kind of say, okay, it's going to be worse. I need to prepare, and just to cue myself to be a little more intentional about doing those things to stay healthier. We did have another sentiment here that we know partners don't want to talk, but there's also the opposite, where my partner won't stop talking about COVID and PPE. And when I get home, I just want a break and pretend that the world is normal. I'm kind of COVIDed out. So it's tough to find that balance. Any suggestions for that?
It's very tough, and particularly for you, because one, I applaud the effort to tune COVID out, and when you get home, you want to do everything you can to avoid it. On the other hand, if you think about your friends and family, you're the expert. You're the one they can turn to trust after they've been hearing all this stuff all day. So they're dying to talk to you about it. One of the things you can do is perhaps take a drive, an extra long drive before you get home, reset, or take 20 minutes and go through a park before you get home. Get yourself reset, give yourself a little bit of free time. And also have the discussion with the spouse, because the situation that got described is leading to a mounting adversarial position. It'll start quietly. You're not going to yell at your partner. The partner is not going to yell at you, but the partner is going to clearly get the clue that you don't want to talk to them, which after they shut down will only raise the level of wanting to discuss things later and be resentful. And you're not going to yell at first, but you want to, and that's going to mount. So not in the moment, but perhaps when you're having coffee or dinner, or things are easier and calmer, have a discussion about just how to deal with it. You could even have, as simplistic as this sounds, you could even have a safe word or exit phrase for "that's been enough." It could be, all right, how about we watch some TV?
Let's see, Heidi is also adding that the graph on the psychological stages of disaster was eye-opening and scary, that the psychological sequelae will last for potentially years. I hope I have the stamina for this.
You will. As I said before, most individuals are very resilient. And this is really community function. Some of it is how we respond, but especially ED docs. When you all come out of this and it's behind you, you will be able to then go back into your professional persona and professional praxis. And you will be able to absorb more just what you've accomplished for everybody else. You may want to just be aware of some of those potential trigger reactions, particularly as it affects your community, the ED community. And one way to use this graph that might be a little less threatening is, just like you want to be aware if there was an explosion or a gas leak at a school so you can be ready for them coming in. If you know that the community may have an increased, call it irrational or hysterical response next January, February, as flu season mounts pulmonary infections, you can be ready for that. And you don't have to fall into that. You can say, okay, yeah, we heard about this. This isn't a pandemic that's going to send us all to hospitals. We got this. So forewarned is forearmed.
Yeah, I think that has helped me too, just thinking about how, like, that the stress increases, that sort of tribalism and things, that I notice that now, and I'm able to go,
Yeah.
oh wow, they're scared, and then try to address it in a more positive and healthy, constructive way. I've really been working on assuming positive intent from everybody around me because it's easy to blame them. So that has been helpful for me as well.
Really important. And I wouldn't just think, and I know you weren't, Wendy, but I wouldn't just think of us versus them as, you know, the siloed ED folks and the general public, but within the ED as a community and even your group as a community, there can be some of that regressive tribalism and us versus them, admin versus line docs, and et cetera. And I think exactly as you described what you're trying to do, and it takes work to do that. You have to tell yourself, no, I got to steer away from that way of looking at it and try to be more accommodating. How can we work together to figure out how to get what we need?
Yeah. Somebody else just commented, it is validating to understand that even though we aren't experiencing that avalanche of COVID patients yet, that there is a real reason that I am feeling anxiety.
Yeah. And I think it's just so important to be able to recognize that you're human beings, and that even though you are pretty much, you know, the toughest and most accommodating professionally, that you can handle just about anything that comes in the door, you weren't trained to handle this internally.
Mm-hmm. And Shelley adds that another stressor is the way that our workflow and all of our PPE has affected us. We've been separated into pods for safety. I can't even recognize the other people that I'm working with, and that supportive just looks and smiles at each other has been taken away too. I've definitely noticed that as well, Shelley.
Yeah, that's again the three-dimensional, the real world aspect of what I was calling praxis. You've depended on almost subconsciously things like the smile, the look, the eye glance, really knowing who you're with. And even though, yeah, you know who they are, it's not the same.
Mm-hmm.
And the fear, the concerns, and the connection to the patient.
Yeah,
Those are all a little different.
absolutely.
And that concludes this presentation. Be well and stay safe.